Good evening, folks. This is Dr. Paul. Thank you for tuning to our channel today. And in today's episode, I would like to talk about polypharmacy. Okay, polypharmacy, that means like prescribing too many medications that they cause harmful effects in a patient. So that is what I would like to talk about today. This is a very important topic because almost all of us, as we grow older, we try different medications, and these medications can cause interactions. For example, benzodiazepines, if you combine them to sedative hypnotic medications, they may have more serious effects on our bodies. So polypharmacy basically means you are giving lots of medications, whether prescription or non-prescription medications to patients. So polypharmacy is many medications. More adverse drug events occur in older adults compared to younger patients for many reasons, because drug metabolism changes as we age. Our kidney function goes down, our liver function goes down. We may have drug interactions with comorbid conditions and also interactions between multiple medications. So polypharmacy itself is associated with adverse health outcomes, because when those side effects increase, people may fall, people may fracture their bones, they may have a disorientation, delirium, okay, they may get hospitalized, they may even die. So medication metabolism is often impaired in older adults due to decreased kidney function, reduced liver clearance, and also changes in body composition. The lean body mass decreases with age, and there is a decrease in total body water and a relative increase in body fat. So water-soluble medications become more concentrated because there is less water, and fat-soluble medications have longer half-lives because there is so much fat. Most emergency hospitalizations for adverse medication events among older adults result from commonly prescribed medications used alone or in combination. For example, sedative hypnotics, anticoagulants, opioids, and hypoglycemic agents. So when you give these medications, or when you prescribe these medications, or when you take these medications, you should take precautions. So if you have like chronic diseases, first think about non-pharmacologic interventions. Okay, first think about whether can I fix this without a medication. For example, you have mild hypertension, think about diet. You have type 2 diabetes mellitus, think about diet. Most medications prescribed for chronic disease should be initiated at the low end of the usual adult dosage range. And you should start at the low dose and you go slowly. Slowly increase the dosage until a therapeutic level is reached or intolerable side effects develop. And at the same time, do not undertreat patients. Okay, so sometimes we undertreat and many people don't get the benefit of a medication. For example, if an elderly man has depression, we start a medication at the low dose, but he is still depressed. That's not a good idea. A person with a high blood pressure, you need to take that dose to the stage when the blood pressure will come down. So optimal medication adherence is less likely with increasing number of pills or doses, high cost, poor communication skills about medication changes, as well as expected benefits and side effects. Other factors affecting adherence include cognitive impairment and insurance issues. A lot of people tell me, hey, my insurance doesn't cover this, so I stopped. So that's a big barrier. Okay. A number of simple interventions can help improve adherence to a prescribed medication regimen. When possible, the clinician should simplify both dosing schedules with the fewest number of pills and doses. Combination formulations can be useful in this regard. If the two medications come in one pill, give them that one pill with two different medications combined. And also modes of administration: oral, ocular, transdermal, subcutaneous, inhalational. We have so many modes of administration today. Other helpful medication management techniques include using a single pharmacy. Don't send people to different pharmacies all over the town. Tell them to use a single pharmacy. And also use a pill box. I have a pill box, 30 days. So every day I open that and I take that medication. So that helps me to take my medication regularly. So pill box, use a pill box. And do not change the prescription all the time. And also communicate well to the patient. Clinicians should also ask patients about their ability to afford their medications. Some people say, I cannot afford this, so I just stop taking it. So what can you do? Of course, we cannot pay their medications, but we can think about switching insurance plans. Medicare Part D, when they are in open enrollment, think about giving them a low-cost alternative to those medications. So the patient or caregiver should bring all medications at each visit in order to achieve an accurate medication reconciliation. Okay, medication reconciliation is an important thing. So patient brings all his medications, over-the-counter, vitamins, nutrition supplements, whatever he is taking, how many times he is taking, what adverse effects you have. So when patient brings all those supplements, over-the-counter medications, and prescription medications, analgesics, sleep aids, you will have a conversation. Medication reconciliation should happen. Medication reconciliation is important if the patient sees different doctors, and that is also dangerous. All right, then we have this prescribing cascade. For example, one doctor gives one medication, patient develops a side effect, he goes to the next doctor. That next doctor prescribes another medication to stop the side effect of that first medication. And then patient develops a side effects to the second medication, and the patient goes to the third doctor, and the third doctor prescribes another medication to treat the side effect of the medication started by the second doctor. So this prescribing cascade goes on and on and on. So that is also dangerous. Patients should stick to doctors, and all these doctors should communicate with each other. They need to write notes to each other, like I started this for this, like that. Including drugs like digoxin. For example, we raise the dosage of digoxin to get the therapeutic level. But that may look normal, but even normal dose sometimes can be toxic in many patients. So you need to look at how much dose this patient is taking, what is the therapeutic window, are there any drug-drug interactions happening, and you can also think about medication discontinuation, that is deprescribing. Deprescribing is a good thing, okay? We feel like giving one more medication to a patient is the good thing, but deprescribing is also a good thing. Medication discontinuation is particularly important in patients with limited life expectancy who may be experiencing increasing burdens from polypharmacy and modest, if any, benefits from the medication. For example, if the patient is falling all over the place because of one medication, but patient has only 6 months to live, it's better that you don't give this medication that is causing him so much distress to achieve a limited benefit, because patient is already in hospice, okay? And now what are you going to achieve by starting all these medications and causing more distress to his life? And he may not be adhering to these medications. So, refer homebound patients with poor medication adherence and suboptimal chronic disease management to a home health nurse. A home health nurse can also do medication reconciliation and teaching, and this home health nurse can call you and tell you about deprescribing certain medications that are no longer helpful to patients. So, polypharmacy is an important issue, and I hope you follow these principles in your own life or in the lives of your loved ones. Thank you. God bless you.